So let's move on to pulmonary embolism. So venous thromboembolism is where we're going to start, and they're going to present pretty similarly to anyone who has an embolism into the pulmonary vasculature, whatever that embolism may be, in this case a thromboembolism. So they'll have shortness of breath, some chest pain, they can syncopize. It's not all that common, but it on occasion happens. Tachycardia is an important part of this presentation because it's the most common part, like of an EKG. Sinus tach is the most common presentation with that EKG finding. It's not going to be some kind of strange SVT or whatever. It's just simple sinus tach. And these patients may or may not be hypoxemic. Oftentimes, if it's a big PE, then yeah, they'll be hypoxemic, maybe even hypoxic, causing the syncope for the moment. But then other times they present with no evidence of hypoxemia. They can still be satting 98, 97% if it's like a subsegmental PE. In terms of working them up, and this is a very common topic, we cover this in cardiology as well because they're almost guaranteed to have not one, but probably, honestly, 2 questions on the exam about PE. It's just such an important part of what we do and can't miss. So you should be familiar with the PERC rules already. And the thing about PERC is you have to apply them to a patient who is not high risk. And you don't have to apply Wells or Geneva. You can actually just use your Gestalt and then apply the PERC rules. And so here are the PERC rules. Now, if the patients meet any of these criteria, age equal to or greater than 50, heart rate equal to or greater than 100, etc., then you cannot PERC them out. The idea about the PERC rules is not you meet all the criteria in order to be ruled out. It's the opposite. If you meet none of the criteria, then you can PERC them out, so to speak. So looking at how you can diagnose this, a CT angiogram is the best way to go for most patients. And so you can see in the left pulmonary artery there, that large clot, it's actually extending a little bit into that trunk, depending on the slice. We don't quite see where it's going. It could be a saddle embolism, but what we can see right there is in that left pulmonary artery. Alternatively, you can get a VQ scan. And if there's any problem with the ventilation portion of this, then a VQ scan is probably not going to be terribly helpful. We talk about this elsewhere, but I think it's important to bring up again as well that the VQ scan can be particularly helpful when you're talking about pregnant patients you're trying to work up for a pulmonary embolism. So they have a higher risk of clot, right, because of the pregnancy status, but you don't want to irradiate them, especially if you don't have to. So if they don't have any leg pain, that particular algorithm takes you down to the chest x-ray first to demonstrate that the ventilation is normal. And then you can actually skip that portion. This is in pregnant patients. Skip that ventilation portion of the VQ scan and just do the perfusion portion in order to try to diagnose that PE. The thing is, again, if any portion of the ventilation is off, that VQ scan tends to be indeterminate. So go with that CTPA anytime you can. You're going to diagnose it partially with the CTA or the VQ, but the next question is, okay, fine, you have a PE, is it massive, submassive, and where are you going to go with it? So in terms of the massive, this is pretty straightforward. They're hemodynamically unstable. The systolic pressure is generally accepted to be less than 90, certainly if they continue to be in some sort of shock, and if they have changes that are making them unstable, if they're no longer perfusing, maybe it's a chronic hypertensive patient whose systolic is less than 90, but they're not really awake, they're not able to talk to you, that's someone who is has a massive pulmonary embolism. And those patients get TPA. The other possibility is submassive and then just regular PE. The submassive issue, there's some talk, right, about the half-dose TPA. That is not part of the guidelines. That is debatable whether or not you're going to do that, so it's unlikely to be tested on the boards. Certainly within your clinical practice, it's worth having the debate and the conversation, but for the boards, it's going to be guideline practice. So the only TPA goes to those with a massive pulmonary embolism. TPA does not go to patients with a submassive pulmonary embolism. And I'm going to say that again because there's a lot of conversation and a lot of people's practices differ from the guidelines. And this is the difference between the test and what you may be practicing in an individual patient, trying to tailor the care to that individual. From the guidelines perspective and for the test perspective, TPA goes for massive pulmonary embolism. TPA is not given for submassive pulmonary embolism. And then in terms of looking at just regular pulmonary embolism, then you can talk about heparin and things like that. So let's take a look, and we have The RV here is larger than the LV, and so we see this strain. This would be suggestive of a submassive pulmonary embolism. So here we go into what you can do with these various diagnoses that you've made. For the submassive, catheter-directed thrombolysis is actually a pretty good option. So the thrombolytics aren't systemic for submassive, but you can do the catheter-directed option. And there's also the option for a suction thrombectomy. For the massive, you're given those thrombolytics, you can do a surgical thrombectomy, and they may wind up on ECMO. It's actually a fairly reasonable indication for VA ECMO to hook somebody up, cannulate them, and then take out the clot. And they have a reasonable chance, so long as they weren't down for a long time, of recovering. Certainly any of these patients are going to be admitted. You can discharge pulmonary embolism. And I hate to admit, I'm already old enough to remember a time that we didn't discharge any of these patients. But if you look at the Hestia score or the PESI score, you can potentially send a fair number of these patients home. Part of this is because the CT scans are getting so good that we're catching all these subsegmental things that isn't really going to make much of a difference, even with that anticoagulation. Some people are even talking about, well, how much difference are we making giving heparin and such, or any kind of DOAC to the subsegmental? Is it worth it? Is the risk worth the benefit? But at any rate, still for the guideline care would be to anticoagulate any pulmonary embolism, and you can discharge based on the Hestia or the PESI. So we have submassive, massive, and if they don't meet those criteria, the regular venous thromboembolism, PE, and you can discharge.